Good morning, everyone. Welcome you all in Pedia Academy by Dr. Pankaj. And today we are discussing GI based table discussion, which is very high yield for your upcoming NEET SS exam. Hopefully, you are doing well in this test series of NEET SS Pediatric 2025. It is one of its kind test series which contain 100% authentic Nelson based MCQs and which are very high probability of asking in exam. So currently we are running offer of 25% off. Okay, so you can join it at pediacademy.com. More about of this later. Now we'll straight discuss GI tables in detail and salient points. Okay, so first table is the esophageal developmental anomalies. Isolated atresia is found in it is seen in newborn. Okay, so newborn presentation is there, and if you see in this plain film suggestive of gasless abdomen. Okay, so esophageal atresia will have gasless abdomen. Obviously, regurgitation of feeding and aspiration will be there. Atresia associated with distal tracheoesophageal fistula in this plain film of X-ray contain gas-filled abdomen, which is very much important. Okay, another entity want to mention here is H type of tracheoesophageal fistula because it is so subtle that it can remain up to adulthood. So age of presentation of this is infant to adulthood very important. It can be identified later also. Recurrent pneumonia and bronchiectasis. This was asked in exam, so this is PYQ. H type of fistula presents late and a diagnosis of esophageogram or bronchoscopy is required. Esophageal stenosis, as the name suggests, it can present to at any age, infant to adults. Dysphagia and food impaction will be there. Duplication cyst. Okay, duplication cyst, it is generally, it presents also infant to adult age group and EUS MRI CT are required. Dyspnea, stridor, cough is the presenting complaint. Vascular anomaly. Vascular anomaly similarly, any age group can be present, can be affected. Dyspnea, stridor, cough occurs. Esophageal ring, okay, and esophageal wave are though two conditions which can occur. So the key take home point in this slide is this: isolated atresia leading to regurgitation of feeding and aspiration. Age group is newborn, plain film showing gasless abdomen. Atresia plus distal TF, plain film gasful abdomen. H-type presents late infant to adult recurrent pneumonia and bronchiectasis, and other thing like duplication cyst, vascular anomaly, esophageal ring, esophageal gap is there. Okay, so moving forward to next, anomalies of stomach. This is also important. So first thing, gastric antral or pyloric atresia. Okay, so this is pyloric atresia. It is not pyloric stenosis or infantile hypertrophic stenosis. This is pyloric atresia. Okay, it presents at infancy with non-bilious vomiting. We understand this fact that uh, any obstruction above the second part of duodenum will cause non-bilious vomiting. So this is important. Pyloric or antral membrane. If it is there's no atresia but membrane is there. Okay, it can present at any age. Okay, so basically atresia symptoms will come early, but web is mild thing to any age symptoms can be there. It will leads to failure to thrive in emesis. Okay, incision excision pyeloplasty will be done. Gastric diverticulum is very rare, but generally its treatment is unnecessary. So this was PYQ. A clinical scenario was there, and gastric diverticulum was given, and treatment was asked. So treatment is generally unnecessary. Gastric duplication. Male to female ratio 1 ratio point 0.2. This is also P by Q. In gastric duplication, females are affected more than male. Okay. Abdominal mass, hematemesis, peritonitis if ruptured. Gastric teratoma. Okay. So gastric teratoma is rare. Upper abdominal mass, gastric volvulus is there. Two things are there: pyloric stenosis, this is infantile hypertrophic pyloric stenosis, and adult form also exists, just remember. And male to female ratio is 1 4 ratio 1. So gastric duplication is more prevalent in female, but hypertrophic pyloric stenosis is more prevalent in male. Again, it will cause non-bilious vomiting, and pyloromyotomy is the treatment of choice. Congenital absence of the pylorus. It is a rare and childhood adulthood condition, and generally it is unnecessary. Okay, moving forward to suggested medication of doses of disimpaction. Just remember few things. Glycerin we give to infant and toddlers. Phosphate enema. This was asked in one of the exam. Okay, so just widely remember phosphate enema more than 3 years, approximately above 100% is the answer. Slow oral disimpaction protocols of PAG. Okay, so PAG is 25 ml per kg body weight up to 1000 ml per hour. 1.5, 2, 3 and 2. Why I'm doing that? Because you have to remember in this order: PAG, milk of magnesia, mineral oil and lactulose. Okay, this is per body weight per day for 3 days. This is disimpaction. And we have like maintenance therapy, so you have to remember this like this. Okay, so milk of magnesia, mineral oil and lactulose both have 1 to 3 ml per kg body weight divided into 1 to 2 doses. uh, PEG is 0.7 gram per kg body weight. And Senna, they once asked, so Senna tablets is 1 to 5 years, 5 ml one tablet with breakfast, maximum 15 ml daily, and 5 to 15 year 2 tablet with breakfast, maximum 3 tablet daily. Okay, now we'll discuss mechanism of diarrhea. Okay, so in this condition, secretory diarrhea. Secretory diarrhea, they will ask what is secretory diarrhea stool examination. It is watery, normal osmolarity with iron gap. Stool iron gap is less than 100 milliosmol per kg. On contrast, osmotic diarrhea contain watery, acidic, reducing substances positive, and os osmolarity with iron gap is more than 100 milliosmol per kg. So you have to remember these two things. Now forward, secretory diarrhea generally persists during fasting. Okay, it is very important. Osmotic diarrhea stops with fasting. Other diarrhea mechanisms are increased motility. This leads to transit time and irritable bowel syndrome. Decreased motility and increased motility both can cause diarrhea. In which condition it is increased motility, like IBS, thyrotoxicosis, post-vagotomy syndrome, dumping syndrome. In which condition it leads to decreased motility? It is pseudo-obstruction, brain pouch. Decreased surface area. In this condition, like short bowel syndrome, celiac disease, rotavirus enteritis. This rotavirus enteritis was asked in exam. So rotavirus enteritis is leading to decreased surface area and osmotic motility. So mucosal invasion by any bacteria can cause. So this is very much important. In this condition, we'll see this. So as we saw this, we'll discuss these MCQs on this table-based discussion, because the only mere reading of tables is not sufficient. So what you is this NEET SS Pediatric test series, which is 6 tests is ongoing. In this Gastro tables, these tables which I'm discussing will be will be given as high yield, very important Nelson based MCQs which will be important for your practice. So after seeing this video on table discussion, go through this gastro table discussion MCQs which is live in this period, and after that it will remain as question bank in this website itself, so please go through it. Okay, now we'll see features which differentiate Hirschsprung disease with functional constipation. Okay, so onset of presentation in functional constipation is around 2 years of age, but Hirschsprung disease it can present at any age. Sorry, it present generally at birth. Okay, failure to thrive is there in Hirschsprung disease. Enterocolitis is there. Okay, abdominal distension and poor weight gain are seen in Hirschsprung disease. Most important thing in rectal examination, Hirschsprung disease it is empty, but functional constipation it is filled with stool. And after removing rectal examination finger, explosive passage of stool is seen in Hirschsprung disease. This is PYQ repeated many times in exams. Okay. Anorectal manometry, again this is PYQ. In functional constipation, relaxation of internal anal sphincter, but in Hirschsprung disease, failure of internal anal sphincter relaxation. So this is important. Rectal biopsy is also important. No ganglion cells increase, acetylcholine staining is there. And on barium enema, you will see transition zone, delayed evacuation more than 24 hours. So these differentiating factors you have to remember. These are very important for exam. Now we will discuss another high yield table of comparison or of symptoms and other things in Crohn's disease and ulcerative colitis. Okay, just see in ulcerative colitis, first we'll dissect this table as which conditions are more commonly UC and which condition more common in Crohn's disease. So I'm just highlighting in different color. Okay, so rectal bleeding and diarrhea are more common in rectal bleeding and diarrhea are more common in this ulcerative colitis. Okay, and rectal involvement is universal in ulcerative colitis. Colonic disease presents in 100% of patients of ulcerative colitis. Toxic megacolon is seen in ulcerative colitis. Sclerosing cholangitis is mostly seen in ulcerative colitis. Risk of internal cancer is increased. Okay, crypt abscess are common and linear ulceration are common, and P-ANCA antibody positive is seen in 70%. Just to remind you once again, rectal bleeding, diarrhea, mucus are more common, rectal involvement is more common, colonic disease is more common, toxic megacolon, sclerosing cholangitis is more common, crypt abscess is more common, linear ulceration and P-ANCA positivity are more common. On the contrast, the disease in Crohn's disease have different presentation. Okay, so like abdominal pain, abdominal mass, growth failure, and perianal disease. Important, these are more common in CD. Okay, so abdominal mass, abdominal pain, growth failure, and perianal disease are more common in CD. Okay, one more thing for ulcerative colitis is that it is this pyoderma gangrenosum. Pyoderma gangrenosum is more common in ulcerative colitis. But on the other hand, erythema nodosum is more common in CD. It's very important. Okay, ileal disease is most common because the distribution of Crohn's disease is more proximal also. So ileal disease and stomach and esophageal disease are more common. Stricture, fissure and fistulas are more common in CD. So abdominal pain, mass, growth failure and perianal disease, stricture, fistula and fissures are more common. Okay, so another thing is discontinuous skip lesions are seen in Crohn's disease and transmural involvement is seen in Crohn's disease and granulomas are more common. So just to revise this fact, this is very important. Abdominal mass, pain, growth failure, and perianal disease are most common in CD. Erythema nodosum is seen in CD. Iliac disease, stomach, and esophageal disease in this Crohn's disease. Stricture, fissures, and fistula seen in Crohn's disease. Discontinuous lesions and transmural involvement in seen in Crohn's disease. So you have to be very well versed with this because this is very much important. Okay, we'll see ulcerative colitis Montreal classification of extent and severity. Okay, so even is proctitis inflammation of limited to rectum. Okay, E2 is the left-sided distal thing inflammation limited to splenic flexure, and E3 is pancolitis. Direct question are generally being asked E1, E2, E3. S1 of remission, no symptom. S1 is mild remission, 4 or less daily stools per day. Just remember this thing. S2 is moderate remission, 4 stools per day, minimal sign of systemic symptom. And S3 is severe, that is 6 or more bloody stools per day, pulse rate of more than 90 beats per minute, temperature more than 99.5, and hemoglobin concentration is less than 105 gram per liter. This is important. This was asked in NEET SS exam, I think 2 years back. So you have to be very well versed with Montreal classification. In which condition it is used? It is used in ulcerative colitis. E1, E2, E3 you should be aware of, and S0, S1, S2, S3 you have to remember these classification. Okay, today we will discuss extraintestinal manifestation of celiac disease, very much important because in INA-CD it was asked. So like ecchymosis and petechia's edema, dermatitis herpetiformis is seen is a probable cause epidermal type 3 TTG autoimmunity, very much important. Follicular hyperkeratosis and dermatitis is seen as a vitamin A malabsorption, and amenorrhea, infertility, short stature is also seen. Type 1 diabetes, so this is immune dysfunction thing. Anemia, hemorrhage, thrombocytosis, holy jolly bodies, pancytopenia, thrombosis, malignancy can be seen. So this can be asked as all except question. Okay, hepatic, hepatic elevated liver biological enzymes and autoimmune hepatitis is seen. Tetany and weakness is also seen. Ataxia is also finding. Demyelinating and central nervous system lesions like immune-based neurological dysfunction, seizures which are difficult to treat, osteoarthropathy, enamel hypoplasia, and pulmonary hemosiderosis, benign inflammatory mass. So basically you have to remember what we have discussed or highlighted. Celiac disease, extra-intestinal features or rare features, these can be asked. So now we'll discuss this National Institute of Health and Care Excellence Guideline on indication of that should prompt of celiac disease. A patient came in your emergency and you want to screen him or her with celiac disease. It is recommended in which condition? Just remember, persistent, unexplained abdominal gastrointestinal symptoms, you should go for it. Faltering growth, yes. Prolonged fatigue, yes. Unexpected weight loss, you should go for. Severe or persistent mouth ulcers, unexplained iron, vitamin B12 or folate deficiency, you should check it. Type 1 diabetes mellitus, autoimmune thyroid disease, irritable bowel syndrome, first degree relative of celiac disease and dermatitis herpetiformis. Just remember mm, everything in this, because this is very much important. In this condition, you have to screen. There is a list of celiac disease should not be considered. Just remember, this is also important. Metabolic bone disease, it should be considered, sorry, means it is like uh, not recommended, but it is should be considered. Metabolic bone disorders, unexplained neurological symptoms, very much important because this is likely to be missed. Unexplained subfertility or recurrent miscarriages, persistent increase of concentration of liver enzymes with unknown cause, dental enamel defect, this was PYQ, and Down syndrome, Turner syndrome, Williamson syndrome, selective IgA deficiency. It is also important in this condition. You have to screen for celiac disease. So it is very clear cut given here. Down syndrome, Turner, Williamson, dental enamel, and SGPT, persistently rise, infertility, and unexplained neurological examination, metabolic bone disorders are the uh, criteria in which celiac test should be considered. Okay, so this is very important. Again, what is the clinical spectrum of celiac disease? Clinical spectrum of celiac disease is divided into uh, symptomatic, silent, latent, and potential. So these are four clinical spectrum of celiac disease. In symptomatic thing, it frank malabsorption of symptom and signs. Okay, like chronic diarrhea, failure to thrive, and extra-intestinal symptoms like anemia, fatigue, SGPT, OT or RIGE, neurological disease, short stature, dental enamel defect, arthralgia, aphthous stomatitis. So these are basically uh, the features of malabsorption or extra-intestinal symptoms. Silent CD is no apparent symptom in spite of histological evidence of villus atrophy. So what is silent? Basically CD. In this, the histological evidence of villus atrophy is there. Means internal is issue is there, but there is no symptom. It is silent. What is latent? It is normal intestinal histology, but at the other time shown gluten-dependent enteropathy. This is latent. And potential positive celiac disease serology, but without evidence of altered intestinal histology. So these terminologies are very much important. You have to remember these all, because otherwise it is very difficult. And for you all to just see this, how this is happening and how questions are framed. We are actually conducting a live test on these gastro tables, because reading tables is other thing, and attempting MCQs in exam environment defined period time is important. 1 minute for one MCQ, there will be 40 MCQ in 40 minutes. So please go through with these tests. These are gold mine and these are very affordable, and you can elevate your NEET SS preparation with this. Okay, now we will discuss diagnostic criteria of cyclic vomiting syndrome. This is important. Okay, so for these criterias, the cyclic vomiting syndrome, these must include all of the following. It is very important. All criteria should be there. The occurrence of two or more period of intense unremitting nausea and paroxysmal vomiting lasting hours to day within 6 months of period. So basically they are saying more than 2 episodes of nausea and vomiting hours to day within 6 months of period. This is first criteria. Episodes are stereotypical in each patients. Okay, these are not just regular thing. Episodes are separated by weeks to month with return to baseline health between episode. It is not like that patient is having vomiting, and after appropriate medical evaluation the symptoms cannot be attributed to another condition. So to nutshell, basically it is more than two nausea episode in 6 months. Okay, and in between normal. So, okay, these are the main characteristics. Other things are like there is no other systemic condition and health is normal and episodes are stereotypical, and these all must be there for diagnosis of cyclic vomiting syndrome. Similarly, diagnostic criteria of irritable bowel syndrome. Okay, in this it must include all of the following. Okay, what are the all of the following? Abdominal pain in children, abdominal pain at least 4 days per month associated with one or more of the following related to defecation, change in frequency of stool, change in form or appearance of stool. In children with constipation, pain does not resolve with resolution of constipation. Very important, and after appropriate evaluation, the system cannot be fully explained by another medical condition. So this was BYQ. So we have to remember irritable bowel syndrome. Now we are coming to very important table discussion of GI, which is actually inherited colorectal cancer syndromes. Very much important. Just pay your 100% attention here. Okay, in this condition, first we'll discuss juvenile polyposis. Name shows juvenile polyposis. So age of onset is in first decade. Okay, and polyp distribution is seen in large, small, and gastric polyps because it is widely spread. So what is the risk of cancer in juvenile polyposis? It was again asked 10 to 50%. And what are the genetic lesions in this SMAD, uh, SMAD 4M BMPR1A? This is autosomal dominant. Everything I'm highlighting or speaking is MCQ, previously asked or potential MCQ, and possible rectal bleeding, abdominal mass into susception will not go into this. We'll see because this condition is spectrum. So congenital abnormalities 20% of non-familial type AV malformation are also seen. So just remember, I'm revising it once again because it is very important. Juvenile polyposis seen everywhere, seen as first decade, 10 to 50% of colon cancer, SMAD4, BMPR1A autosomal dominant, and associated with AV malformation. So it is very important. Next entity is Peutz-Jeghers syndrome. It is also very important, and the classical distribution of this disease is seen in small and large intestine. Similarly, of juvenile polyposis, it is seen in first decade. Obviously, cancer risk are increased. But what are the genetic lesions? LKB1, STK11 genes are involved. This is definitely PYQ. Okay, and Orthocutaneous melanin pigment spots are seen in Peutz-Jeghers syndrome, which is classical hallmark of this condition. Another thing is Cowden syndrome. So C for Cowden, C for colon, and it is seen in second decade. The gene is P10 gene, and just see macrocephaly, breast, thyroid, endometrial cancer, and developmental delay is also seen in Cowden syndrome. So it is gold mine table you have to remember because it is ultra important. So Cowden syndrome, colon, second decade, P10 gene, and developmental delay, endometrial cancer, and macrocephaly very much important. This banyan relay Ruel-Cabas syndrome. So this syndrome is also similar to similar to Cowden syndrome because it is seen in colon, second decade, P10 gene mutation, macrocephaly, speckled penis hemangioma. So if Cowden syndrome-like presentation is asked, but speckled penis and thyroid and breast cancer like hemangioma is seen, it is Banyan-Rivale Rubalcaba syndrome. Just remember. Adenomatous polyposis. This is familiar adenomatous polyposis. It is seen in large intestine and more than 100 lesions are there. Age group is 16 years, but the range is 8 to 34 years. 100% risk of cancer, very much important. The gene locus is 5q. APC gene, it is autosomal dominant PYQ. Rectal bleeding, seen abdominal pain. Along with this, desmoids, upper GI polyps, osteoma, hepatoblastoma, and thyroid cancers are also seen. This entity of FAP is asked multiple times in multiple exams, so you can't miss this. Okay. Attenuated FAP. What is attenuated FAP? It is seen in colon but in fewer in number, more than 18 years, and it is fewer lesions. You don't have to remember. MYH associated polyposis, also seen in colon more than 20 years, and it is maybe confused with sporadic FAP and few extra intestinal finding. So basically it is confusing entity with FAP. Gardner syndrome. So Gardner syndrome is also large and small intestine. Age group is same as familial adenosis polyposis, and 100% like FAP malignant potential is there. Gene is 5q. Okay, APC gene is same, and desmoid tumor, multiple osteoma, fibroma, epidermal cyst. So Gardner syndrome, FAP shares mostly similar presentation. Lynch syndrome. This is hereditary non-polyposis cancer syndrome seen in large intestine. Age group is 40 years. The malignant potential is 30%. It is due to DNA mismatch repair gene MMR, which is autosomal dominant. Other tumors in ovary, ureter, pancreas are also seen. So this is very much important. Okay. Okay. One more thing, pediatric appendicitis score. Just remember fever more than 100.4, 1, anorexia 1, nausea vomiting 1, cough, whooping tenderness 2, right lower quadrant tenderness 2, migration of pain 1, leukocytosis 1, polymorphonuclear neutrophilia 1, and total is 10 score. So again, I'm reminding you once again, this is ultra important, and we are actually running this test series of NEET SS Pediatric. It is very affordable. Just go through link which I'm providing in this description and pinned comment. Just go through these tests. These are very high yield because just reading and doing MCQ is very different. So in exam, every question counts because it is time bound and competition is very fierce. So don't miss the chance to have this amazing test series of NEET SS Pediatric, which is loved by students who have joined. Okay, so don't regret it later because time is less, time is ticking. So please go and subscribe this amazing test series. We'll meet in another video. Keep reading, keep doing MCQs, keep giving test series. Good